Good morning, everyone. I am Dr. Vijeta, and today we are going to discuss ovarian reserve and its assessment. Before going to the main content, I'll tell you where I have taken the content from. So, the content of this discussion was taken from Testing and Interpretation Measure of Ovarian Reserve ASRM 2020 article, Sparrow and Gardner. So now the objective of our discussion is what is ovarian reserve, female reproductive aging physiology, ovarian reserve implication and various ovarian reserve testing. So let's discuss the first question, that is what is ovarian reserve? So, ovarian reserve refers to the size and quality of the remaining ovarian follicular pool and the ability of the ovaries to respond to the exogenous gonadotropin stimulation. This I have taken from Sparrow. Let's come to the other definition. Let's discuss the another definition of ovarian reserve that I have taken from Gardner. It describes as the quantity as well as the quality of the remaining oocyte in both ovaries at a given age. So what do we understand from quantity and quality? So the quantity means basically the number of oocyte at that particular age, and if there is decline in the oocyte number, then it will lead to irregular cycles and ultimately the cessation of menstrual bleeding. What do we understand by quality of oocyte? The quality of oocyte, it will relate with the potential of the fertilized oocyte to result in live-born infant. And if there is decline in the oocyte quality, then it will result in decreasing the fertility and defined as a capacity to conceive and give birth to a child. So the another definition, one more definition, which was given by ASRM 2020. So ASRM 2020 defined ovarian reserve as the number of oocytes remaining in the ovary or the oocyte quantity. They have not described about the oocyte quality. So the definition here is only the number of oocyte with respect to the other definition, which has taken account of both the quantity as well as the quality of oocyte. Let's now discuss about the female reproductive aging physiology. So as we all know, there is decline in the oocyte from birth to the menopause, and in the infant period there are around 1 million oocyte, and follicular atresia and ovulation result in depletion of the oocyte number over time and lead to menopause. So ovarian reserve inversely correlate with the aging. As the age increases, the number of oocyte will decrease. Let's come to this chart in which they have described the number of oocyte at birth, puberty, menopause. As we can see, at the 20 weeks gestation, that is the maximum number of oocyte is present at this time, that is 7 million. At birth, it is about 1 million, and puberty, it is around 3 lakhs. At menopause, it declined to 0. So because of the process of atresia, as shown in the red arrow, and ovulation, which is shown in the blue arrow, there is declination of the oocyte number, lead to the decrease in the ovarian follicle. This graph also shows the same thing. The dark black arrow line represent the number of follicles which gradually decline as the age advances, and the dotted line, which represent the oocyte quality, will become poor as the age advances. So what is the implication of ovarian reserve? Let's Ovarian reserve helps us to identify individuals who are at increased risk of diminished ovarian reserve, which is defined as women of reproductive age having regular menses whose response to the ovarian stimulation is reduced relative to the women of comparison well age. So two women, both are of same age, that is 30 year both. One responded well, other didn't responded well. So we have to basically identify those women who didn't responded well, and these women have decreased or diminished ovarian reserve. So what is the predictor of ovarian reserve? Best predictor of ovarian reserve. It's the female age, which is the single most important predictor of fecundity. And how ovarian reserve help us? So the basic goal of the ovarian reserve testing is to identify women who may be a poor responder to gonadotropin stimulation in order to tailor their treatment and to discuss and counsel about the expectation of the patients in response to the treatment. Let's discuss various ovarian tests. So they can be broadly divided into two categories. That is, first is biochemical test and the second is ultrasonographic measures. Biochemical can be further divided into three, that is basal or early follicular measures. Second is cycle day independent. Third is provocative test. Basal includes the tests which are done on day 2 to day 4 of menstrual cycle, which include FSH, estradiol, inhibin B. Cycle day independent include anti-Mullerian hormone. Provocative tests include clomiphene citrate challenge test. We'll discuss these in detail in the further subsequent lecture. And the ultrasonographic measures include antral follicle count and the ovarian volume. So these all tests are very poor predictor of conception, and women should not be told that if the ovarian reserve is low, that they cannot conceive spontaneously, or should not be denied fertility promoting treatment including ART based on the finding of decreased ovarian reserve. So this is for today. I hope you enjoyed the lecture. Thank you.